All right, so our research was on COVID-19 stimulus funds for nursing home and the quality incentive program. And so we'll have an introduction, talk about the research and the data set information, our conjectures, the analysis process, literature review, methodology, results, and then conclusions. So obviously the SARS respiratory syndrome coronavirus 2 or COVID-19 has been a global issue for quite some time, a span of about 2 years. And so this topic is going to be, and has been already, the topic of multiple research, and it will be most likely for decades to come. And so the government funding from the Department of Health and Human Services, or actually a consortium of several different entities, we're dividing up $2 billion to nursing home facilities for relief of coronavirus incurred expenses. And obviously congregate care facilities are paid by the people that are using their facility, but as expenses incurred by the coronavirus have obviously put a financial burden on those facilities in a way that they obviously need assistance from the government. So how to allocate those funds in a fair and impartial manner is a concern. When you start to have billions of dollars that are going to be divided up, it has to be done in a fair way. And so there has to be metrics for that distribution. And what we try to do is just see if there's, excuse me, any possible funding anomalies that could be detected. So the Nursing Home Quality Incentive Program, this consortium, the CARES Act, the Paycheck Protection Program, Healthcare Enhancement Act, that PPPHCEA, the Coronavirus Response and Relief Supplemental Appropriations Act. They actually provided the formula and for the funds to be distributed via the Department of Health and Human Services. So the study that, or the data that we used was before the vaccine. It was the last 4 months of the 2020 is what we evaluated here. So the allocation metrics dealt with the infection rate and mortality rate in facilities versus in their surrounding communities. And I'll get into that in a little bit. There was stringent eligibility requirements, and they were rigorously monitored by the National Health and Safety Network. So the performance score was developed by that consortium and to determine how the funds were divided up. So the data set consisted of over 33,000 elements, each with 15 attributes, and the attributes were as follows. The Medicare provider number, the CCN, facility name, city, state, zip code, the total resident weeks, which was the number of beds filled per week on average, total COVID infections, facility infection rate per 1,000, county infection rate per 1,000, infection performance score, the capped performance score, mortality adjustment, performance month, and final payment. All 50 states were represented, along with District of Columbia and Puerto Rico. And that data we got from data.gov, data set that was publicly available. And so the steps for the performance score, I'm not going to go through all of that. It's in the literature, but it's briefly what I have listed. So they summed each week's infections and then reported the COVID admissions, the people that were admitted during the week that had COVID were not counted against as a case that was developed in the facility. So then they took a ratio of the infection, the infections reported to the total resident weeks, and then sum that up. And then they assumed that the infection rate mirrored the county infection rate and got an expected number of infections, and then took the difference between those two. And that formula is all in the documentation. This is just a brief summary. So they did that for infections, and mortality is a very similar calculation for that. All right, so our conjectures were that facility infection rate would be positively related to county infection rate. So the surrounding community would affect the facility, and then in a positive manner. The facility infection rate would be positively related to infection performance score. So the score developed would reflect that. And then the facility and county infection rate would be positively related to the final payment. All right, so our analysis process, we looked at each of the numeric variables in a univariate evaluation. Then we paired the variables for a bivariate evaluation, then moved on to two different multivariate evaluations, the ordinary least squares, and then the cross-validation, predictive modeling, and then summarize the findings. So in a literature review, looked at a lot of different articles, and there were mixed reviews. This was early in the pandemic, so before vaccine. So a lot of people were trying to determine if this had opinions on if this funding formula was working in the way it should. And one of the largest things is that the population in congregate care is around 1% of our population, but at that time, that was 40% of the COVID-19 deaths. So it was obviously a huge problem with congregate care facility, and continues to be with older people for sure, and the rest of the population. And it was given to facilities with effective infection control practices. So they wanted to reward the people that were, or the facilities that were doing the correct things to protect against infection. But one of the, not really anomalies, but issues is that if the surrounding communities had low infection rates and the facility struggled, it was going to be difficult to perform well on the funding, with the funding formula. And so a lot of those places, facilities were exited from the program. So, and the converse was true as well. I know, for example, I read an article, and it's cited in the paper, that in our neighboring state, Wisconsin, the infection rate in the local community was fairly high. So facilities did a nice job of staying below that, and then they reaped the benefit of the formula. And one of the articles cited that 2% of the population of Wisconsin in congregate care, Wisconsin made up 2% of the congregate care facility population in the nation, but they were able to get 4% of the money allocated. So that kind of one of the idiosyncrasies of the formula. But as anything with government, we try to do a good job of targeting the people in need, but if you look at specific scenarios, sometimes it seems like it's not as fair. So mixed reviews on that. So our formal hypotheses were these. Our null hypothesis that the relationship was not present in the data, and then H1, the county infection rate, will have a positive impact on facility infection rate. And facility infection rate will have a positive influence on the infection performance score. And then facility infection rate and county infection rate will dictate a facility's infection performance score and therefore the final payment. So this was our univariate bit of evaluation. So you can see that each of the states was represented along with Puerto Rico and District of Columbia. We were in Minnesota and Wisconsin right here. So roughly middle of the pack as far as participation. All right. Nope. And other univariate evaluations, so mean, standard deviation, min, median, max. So a quick snapshot of the data sets. So this is all of the variables here with the short descriptions, and then a snapshot of the statistics. You can note that the mean and median for each show you that every one of these was skewed to the right. And this is a visual representation of that. When we looked at the data bivariately, so developed a heat map with correlation calculated in the regular way, Pearson. So the heat map showed final payment and infection performance score highly correlated. Infection rate with total COVID infection also highly correlated, and they could have a linear association, but obviously correlation does not necessarily indicate linear association. So referring to our original assumptions, facility infection rate would be positively related to county infection rate, and we see that it is true. R is 0.39, so not terribly correlated. Above 50% or more toward 80 or 90 would be better, or more strong in that assumption, but it was positively associated. So also expected was the relationship between facility infection rate per 1,000 and infection performance score. So yes, that was true, but not a very strong association at all. And lastly, a positive association with the facility infection rate and county infection rate. And so both of those were true as well, but quite a bit stronger with infection rate per 1,000 weeks, resident weeks. So that was justified. So on here are what I did was look at the overall correlations for all of these paired variables, and the overall very high for each, but notice when I break it out by months, it varied some. So I have a picture of that. It's a graphical representation. All right, now notice a couple of evaluations here. So if compared to your overall correlation, the monthly for final payment and infection performance score, along with total infection and facility infection rate per 1,000 resident weeks, remained consistent. However, you notice that some of them, the correlation between them became a little looser as we broke it out by months. So total resident week and infection performance score showed increased correlation over a 4-month period. So it started weaker and it became stronger and then county infection rate per 1,000 weeks, and infection performance score weakened significantly, but that was actually, I believe, the goal of the program. So if you recall, this right here, the infection performance score and the county infection rate, that's this one right here, this became less correlated, which again, I believe that was the goal of the program, is to detach the facility from the county. If you could do better according to the surrounding area, then that would signify that you're having success fighting the virus, or at least keeping it away from your residents. All right. Excuse me. And so I checked for a log, took the log of all the data and checked for normality in that, because everything was skewed. Any data that had a 0, I adjusted so I could take the log. And then, so these are the multivariate evaluations, so coefficient of the ordinary least square regression model with probability. All right. And then a cross-validation score for tenfold cross-validation procedures. So that, excuse me. So broken into 10 disjoint folds. And we use the remaining 9 for training, and the one in question was used as the test data. All right. So quick evaluation of those results. When the final payment is predicted using the variables that were not contrived, so IPS and MA, so they were moderate positive correlation. So positive contributors were final payment, total COVID infection, total resident week, with facility infection rate as the largest detractor. So it had a negative impact on the results. So county infection rate was positive, but its coefficient was basically 0. So it didn't contribute as much to the formula. And the results tend to support the design of the infection performance score and the mortality adjustment. So our conclusion, so obviously when there's a severe situation like a pandemic, you need to rapidly show a rapid response. And so, but proper evaluation of the response measures is always a good practice, and especially when a lot of money is at stake, then it should be good to self-check, right? And so were the goals met for the program? And the goals were to incentivize facilities that did the right thing. They could keep the infection away from their residents as compared to the surrounding community. So, and obviously, if we evaluate these scores and say, how did we do, that'll be helpful in future decision-making about the funding. And so they wanted to derive a system that would distribute the funding tied to the facility's performance. And I mentioned that compared to the mortality in the surrounding communities. And infection performance score and final payment were very strongly correlated. So that's providing some transparency to the method of allocating the funds. So successful facilities did manage to outperform their communities in disease, infection, and mortality. So as usual, when you do some sort of analysis like this, there's discussion of things, other things that become made light of so get discovered as you go through. And again, this was only for the last 4 months of 2020. So really this happened before any vaccinations or anything like that. So it would be nice to see this data over a longer period of time to help determine if trends in the funding could be noted. So with only a 4-month period, it was pretty difficult to determine a trend. So it'd be nice to examine this type of data over a longer period of time, see if there was any anomalies that would arise. So, and how were facilities that were disqualified, how would they compare if we could look back now and see if they outperformed some of their counterparts, or if the lack of funding, if they were disqualified from the program for some reason, it would be interesting to study that facility as compared to those that were able to stay in the program and receive extra funds, and see if it would be another indicator that extra funds actually helped. And one could argue then that the facilities that were disqualified could arguably use the funds more than the ones that were able to stay in. So, but that's one of the kind of issues that comes up when you try to standardize a formula. So, so that would also, if you could see a disparity in facilities that were able to stay in the program versus the other, then that would be obviously an excellent indicator that the extra funds helped. So all of these results are given for reader's insight and interpretation. And as usual, more questions are unearthed that pique our interest and merit further study. So thank you for listening. Thank you for Dr. Al-Azzam giving me this opportunity, and also our